Uh, dear Dr. Nghĩa, dear Dr. Mingan, good morning to everyone. My name is Phan Phúc. I'm come from Neurology Center, Bạch, my hospital. We all know that started epilepticus is a common neurological emergency, and timely access and manage is really difficult. Today, I will present about diagnosis and treatment of started epilepticus in Neurology Center, Bạch, my hospital. The newest definition of international knowledge against epilepsy in 2015 noticed the time point T1 and T2. We have to treat at the time point T1 because it's a time of failure of mechanisms for seizure termination, and we have to control the seizure before the time point T2 because after that it can lead to long consequences, including neuronal death and change neuronal network. And we can define the time for generalized convulsive started epilepticus and focal started epilepticus with impaired consciousness, but data are not yet available for another form of started epilepticus. The classification is very complicated, and in clinical, the seizure type can involve, and with non-convulsive started epilepticus, we diagnose and follow the patient based fundamentally on EEG. The magnetic resonance imaging in started epilepticus used to diagnose the etiology, and in some cases, it helps us to it can reveal the presence of image conducted by seizure themselves. EEG has a role of diagnosis, treatment, and prognosis for in started epilepticus, and the pleomorphic EEG patterns reflect with this wide variety of clinical types. And most research on started epilepticus has been conducted in high-resource countries. But the developing country like Vietnam only bear a disproportionate burden of started epilepticus, but we have a large treatment gaps in started epilepticus. Therefore, we conduct research on diagnosis and treatment of started epilepticus at Bạch my hospital. We select on 71 patients diagnosed started epilepticus in 1 year. About general characteristic, we can see that started epilepticus seem like a bimodal distribution, high risk in the older patient, and in our center we don't have pediatric patient, but we have many patients with autoimmune encephalitis and many patients with new onset refractory started epilepticus. So we have the high rate of younger patient predominant in the female. About etiology, the most common cause of started epilepticus is cerebrovascular disease and central nervous system infection, predominantly in the elderly patient. With the younger patient, we usually find autoimmune encephalitis, and you can see that the high rate of cryptogenic started epilepticus. About some characteristic of clinical sign, most of the patients come to us with the sign of seizure, about 66.2%, and 42.3% of patients have decreased the level of consciousness. Another sign we can see is memory deficit, hemiplegia, aphasia, or headache. With the patient have seizure, the most common type is focal onset impaired awakeness, and about 26.6% of patients with the generalized onset seizure. And many patients come with us, we have moderate to severe consciousness disorder. About classification, we have 74.6% of the patients have started epilepticus with prominent motor. And you can see that we have a high rate of non-convulsive started epilepticus, and all of the patients with non-convulsive started epilepticus with coma require anesthetic drugs, and all of them have a poor outcome. In our center, we don't have a continuous EEG, and we can use MRI to follow up the patient, but all of the patients take MRI and EEG. And we have 71.8% of patients have abnormal on MRI, and about 80.3% of patients have abnormal on EEG. And there are some characteristics can be a prognostic factor in EEG with rhythmic or periodic activities can a prognostic factor of worse outcome. And there are some characteristics can be relevant between clinical and MRI with EEG. Enhancing lesson on MRI or cognitive disorder can relevant to rhythmic or periodic activities. About treatment, the first choice for first-line treatment of status epilepticus is midazolam, with about 70% of the patient. In our center, we just have sodium valproate intravenous to use in the second line of treatment status epilepticus, and with sedative, we usually choose midazolam, and about 7% of patients we have to combine midazolam and propofol to control the seizure. In the case of the second-tier use of anticonvulsant in status epilepticus, there was a clear preference of levetiracetam, about 64.8% of the patient, and we usually use valproate and carbamazepine too. You can see that non-convulsive status epilepticus usually seen in the elderly patient, and the patient more than 60 years old usually have a moderate to severe cognitive disorder, and they have a worse outcome. But the younger usually require anti-epileptic drugs combination because of high risk of drug resistance. The length of stay of convulsive status epilepticus is about 24.8%, 24.8 days, and with the non-convulsive group is about 15.7 days. As you can see in this table that there is no statistically significant difference between non-convulsive and convulsive status epilepticus in some aspects, like using intravenous anesthesia, sodium valproate intravenous, or vasopressor. The most common complication of status epilepticus in our center is pneumonia, with about 66.2%, and about 11.3% of patients have hypotension due to using anesthetic drug. So status epilepticus is a common disease with a severe prognosis, and older people, etiology, and some characteristics on EEG are prognostic factors, and it is necessary to coordinate clinical MRI and EEG to diagnose prognosis and evaluate treatment effect. Diagnosing of non-convulsive status epilepticus is challenged. Non-convulsive status epilepticus has a high rate of morbidity and mortality. In the process of assessing specialized tools for diagnosis and treatment similar to developed countries, we need to adapt the tools we currently have. So with status epilepticus, time is brain, but it's really difficult to identify the time to treatment and difficult to follow the patient. So we hope that we need to discuss more about this topic in the future. Thank you for the attention.
Thank you, Dr. Phúc, for your very comprehensive presentation. You keep the time, yes, just only 10 minutes.